Good day, everyone, and welcome to the June edition of the Get Webinar Series 2026. Thank you for joining. Thank you very much for joining this important conversation today. My name is Faith Omalade Adebayo, and I serve as a research and program officer at the Global Emerging Pathogens Treatment Consortium, GET. It's my pleasure to have you all here today, and I will be your moderator for today's webinar. And I'm delighted to welcome everyone. Thank you for joining from different parts of the world. And on behalf of GETS, I would like to sincerely appreciate everyone for taking your time to be with us today. It's such a pleasure to have you, and we extend our gratitude also to our distinguished speakers who have generously made time to share their expertise and insights with us. Like we used to say, we do not pay them, and they are doing this out of their free will. So we are truly honored to have them in our midst for this important conversation. Before we go on, kindly introduce yourself in the chat box and let us know wherever you're joining from, your name, wherever you're joining from in the chat box. My name is Faith. I'm joining from Nigeria, and I'll be your moderator for today's session. I'm a program officer at GET Consortium. So we want something similar to that, your name, wherever you're joining from, your organization, and the likes. So as we are all aware, infectious disease threats continue to place significant pressure on the global health system, and Africa remains at a critical point in strengthening preparedness, improving response capacity, and building resilient system that is capable of addressing both emerging and re-emerging public health threats. So this conversation is very timely because of the ongoing Ebola outbreak that is currently affecting major parts of Africa, including Uganda and Republic of Congo. And it once again reminds us that infectious disease spreads quickly and can escalate and overwhelm our health system. It can disrupt communities. It can place pressure on national and regional response mechanisms. And as of 17th of June, 2026, we've had 896 confirmed cases of Ebola. We've had 232 deaths with a CFR of 62%, and we've had 78 patients recovered. And also we have 6,367 contacts under follow-up. This is quite a number of people, and it is very important that direct health impacts like Ebola continue to expose the persistent gaps in our emergency preparedness in Africa, in our surveillance systems, in our cross-border coordination, and overall the resilience of public health system across the continent. So it is very important that we have this conversation, and not only have the conversation, we take action. So at a time where global health systems are already navigating multiple competing crises, from Ebola to dengue fever to a lot of diseases, today's conversation is very critical, which is why GET is convening this webinar to discuss the theme, building resilience against infectious disease threats in Africa, strengthening preparedness, response, and regional health security. But before we begin, I would like to mention a few housekeeping notes. Like I mentioned, we are highly encouraged to introduce ourselves in the chat box, your name, wherever you're joining from, and any other information you would like us to know about yourself. And we would also welcome your comments and engagement throughout the sessions, right also in the chat box. And if you have questions, the questions can be directed to the Q&A box, which will be addressed during the discussion segment towards the end of the webinar. Now, without taking much of our time, we'll begin with the webinar. And to open our discussion for today's webinar, we'll be beginning with a topic that reflects the urgency of why this conversation is very important. And it's my pleasure to introduce Ms. Jenny. She's an epidemiologist with the National Institute for Communicable Disease, South Africa. She's an accomplished public health specialist, currently serving as the provincial epidemiologist for Western Cape Town. And in this critical role, she bridges national and regional health strategies through a joint appointment with the National Institute for Communicable Disease, a division of the National Health Laboratory Service, and the Western Cape Government Department of Health and Wellness. With extensive expertise in outbreak investigation, infectious disease surveillance, data-driven interventions, she has been at the forefront of managing regional health crises, and her recent work includes leading investigations into foodborne illness clusters and co-authoring research on outbreaks in the Cape Town metropolitan area. She holds a Master of Public Health and specialized through the South African Field Epidemiology Training Program. Throughout her career, she has dedicated herself to strengthening surveillance system, improving tuberculosis and HIV project coordination, and safeguarding community health. Today, she will be speaking on responding to ongoing Ebola outbreak in Africa, emergency preparedness, containment, and lessons for future epidemic response. Jenny, the floor is yours. Thank you for this opportunity, and you can now go ahead.
Perfect. Thank you so much, Faith. So I am busy sharing my screen and I'm hoping that it's going to share. I am just going to switch off my video. Great to see everyone. I'm just going to switch off my video for bandwidth. Thank you so much, Faith. Are you able to put it into presentation mode, please? Can you please confirm that you can hear me?
Recording in progress.
Yes, we can hear you, and we have your screen up. Confirm if you can see it.
Yes, that's perfect. Thank you. I can see it. So, as Faith mentioned, what I'm going to talk to you today is about responding to ongoing outbreaks. But I'm not going to focus specifically on Ebola just as the disease. But I would like to talk about processes and procedures and systems that we can put in place for us to respond. Because as Faith mentioned, we are dealing with the Ebola outbreak, but we do have ongoing outbreaks and we have other health emergencies as well. So if we put in systems and structures that could help us to respond to all of these hazards, that would make our lives so much easier. Thank you, Faith. Next one, please. So I think Faith gave us an updated overview of what is happening at the moment. The situation is quite dire. We do have I think it's over 1,000 confirmed cases in the DRC now, with a really high case fatality rate. And we also have confirmed cases in Uganda. And the situation at the moment is very complicated. So where the outbreak started, there's a lot of migrant populations there's a lot of refugees. So at the start, this was already a very complicated outbreak to begin with. Next slide, please. And what we have seen is that things are not going too well at the moment. So the news headlines, if we follow it, it does give a view that, you know what, they are struggling at the moment. We have healthcare workers that got infected with Ebola, and some of the reports are saying that there's not enough personal protective equipment which is really not something that we would like to see in 2026. A country struggle with PPE, and this is why we learn from our previous pandemics and we try and we help the country. So we fix our systems and we help to contain the outbreak where it is. So WHO and Africa CDC is saying, you know what, this might be one of the biggest outbreaks that they've ever seen, and it might continue even up to a year. So we really have to prepare for this. Next one, please, Faith. I'm not going to go into details about, specifically what we do for Ebola or the situation and the challenges that they're facing at the moment. Faith, next slide, please. Okay, so I don't know, I'm not seeing the presentation on my side anymore.
Do you mind presenting from your end? We have a bit of connection issues.
Okay, sorry, just give me a minute to see if I can.
Sorry about that.
It's okay, it's understandable, it happens. Let me just see if I'm able to share. I will just have to log in on my laptop quickly to share. So while I'm doing that, so what I was saying is I'm not going to today really talk about the response to this current Ebola outbreak, because the WHO and Africa CDC, they are doing a number of press briefings. They do a lot of publications, they do situational overviews. So if you really want to understand the nitty-gritty, like what is going on at the moment in the DRC and in Uganda, then I would urge you to follow Africa CDC, follow the WHO, and you can, sorry, I'm just trying to share as well while I'm talking. So if you have a look at that, thank you, perfect, thank you. So please follow Africa CDC and WHO, and they would give you a really good update. Yes, this is perfect. If you can please put it in slideshow again. So everything is, like I mentioned, on Africa CDC's and the WHO's website. But what I want to talk to you about today, as I mentioned, is putting in structures and processes that would help you to respond to all hazards. So we're not just talking about infectious diseases, we're talking about other hazards, floods, natural encounters, and things like that. So one of them, and I'm very happy that we have someone from the WHO's Health Emergency Prevention, Preparedness, Response, and Resilience team. So through this HIPAA framework, the WHO proposes 5 core systems that every country should strengthen. And as I mentioned, we are doing this through an all hazard approach. So we don't just focus on infectious diseases, we focus on an all hazard approach so that we can respond collectively and effectively. Next one, please, Faith. So for today, I want to focus on emergency coordination and how that could help us. So if we have really strong coordination structures and strong leadership, then we can put in place processes. We standardize processes across countries. And we know that structures and systems drive these processes. Are you not seeing the slides again? I'm seeing the slides, Jalal, so maybe just check from your side, please. Um, so if we have really good coordination systems, okay, nope. Did GT drop off? Are you able to see the slides? I see some people are saying they're not able to see the slides.
Can you all see the slides now? The slide is up. Please confirm if you can. You can use the reaction button, thumbs up, or respond via the chat.
I can see the slides on my side.
Thank you.
Okay. Perfect,
Okay.
thank you. So we can continue, and apologies for the technological mishap. So the coordination structures and leadership structures. So it helps to give guidance, it gives direction, it can identify any gaps, that people are struggling with, and it helps to address these gaps. Also, because we don't have a lot of resources, it helps to optimize the resources that we do have. So really talking about coordination, for me, it's one of the important things together with these other 5 C's. So we call it the 5 C's of the HIPAA framework. That's emergency coordination, collaborative surveillance, community protection, which is very, very important in an Ebola outbreak, safe and scalable care, and access to countermeasures. Next slide, please. Okay, so the coordination structures can differ from country to country. It can be through national public health institutes, and we have set of links here that would be talking to, a lot of the work that IHAMSI is doing and the importance of NPHIs within emergencies. It can be done through public health emergency operation centers, which is PHEOCs. And Africa CDC did publish the PHEOC, Africa CDC PHEOC handbook, which is really good in describing like what a PHEOC needs to do, the roles and responsibilities, how to establish a PHEOC, but it's really good guidance. And we do urge countries to set up a PHEOC structure. And I know some of the countries like Kenya are doing well. They have a provincial PHEOC, but they also have county PHEOCs. So the countries are doing very well. And then often how we respond our emergency coordination structures are through an incident management system or an incident management team, which is what I'm going to talk a bit about. Faith, please share. Next one, please, sorry. Okay, so this is very, I know, very detailed, and you can't see a lot. Don't worry about it. I'm going to go zoom into some details. That's a bit too far. If you can go back to that very big diagram, please. And back again. Okay, so this was prepared by our Emergency Operations Center Manager at our NPHI, which is the NICD. So this is the ideal structure for a viral hemorrhagic fever outbreak, such as for Ebola and Bundibugyo virus. So really, and what you can, if you have a look at this, you see it can be quite complicated. So we have a lot of functions that needs to be done by the planning team. Remember, I spoke about the leadership being so important, about the operations team, and we have media liaison, we have RCCE. So it is really a very complicated response that we need to have for VHF, with its multi-government, all of society, all of the community. We really need everyone on board for this. Please, the next slide. So then on the next slide, we'll see this is now if we zoom into our IMS structure for the VHF response. And again, in the Africa CDC PHEOC handbook, they are describing what an IMS structure is if you want to go and have a look for it. But essentially, so we have the strong leadership at the top, as I mentioned. We have our senior command staff that is able to help us, that is able to guide us. And then we have all of our different sections, operations, the boots on the ground, the people going out doing the investigation. They can't do anything without the planning section because we need cars, we need cell phones, we need tools to go out. Logistics, we have financing, because we know financing, funding, always a challenge, but we do experience during outbreaks. So we need to find a way for us to get money and to really move through the supply chain quickly because we can't wait 2 or 3 weeks for PPE if we have an Ebola case now. We should have already stockpiled it, but if we need something very quickly, we need to get it and we get it now. And then liaising with all of the other departments as well and the other sectors. Next slide, please. So then a good example of Ebola virus operations team is what I'm presenting now. So we start with our community engagement branch, right? So this is what all of the countries need to be doing now. Already talking to the community. Okay, this is the situation in DRC and Uganda. It's low risk for us. We have a look, we use our community-based surveillance, we use our event-based surveillance to see if there are any rumors about people being sick and people that have traveled from DRC or Uganda. So we really start with them. We know clinically we have to take care of these people. So are we going to put up Ebola treatment units? Do we have enough space in our hospitals, in our isolation units to take care of them? Do we have the specialists for that? Then contact tracing, I think it was mentioned as well. Contact tracing is one of the most effective measures for VHF control. And unfortunately, DRC is struggling a bit and they're not able, due to a lot of reasons, they're not able to get to all of their contacts. So if a contact becomes a case, then of course they can easily transmit the virus again. IPC again in Ebola, very important. So we need to train people at the moment. We need to make sure we've got PPE. We don't want the situation as DRC is facing at the moment where the medical staff do not have PPE. So we really want to start focusing on that now. Of course, we safe and dignified burials that's culturally appropriate is so important because we do know that the body of someone who demised from Ebola is very contagious. But we do also know that people have procedures of how they prepare the body for burial. So we can't just come in and say, no, you can't do this anymore. We really have to engage with them and we need to get to a place of where we are both happy. This is what we can allow you to do because it's safe and this is what you're okay with. So how you can get to this IMS structure, next slide please, Faith, is what I want you to do is I want you really to use your imagination, go back to your childhood era, and I want you to map out like a potential Ebola patient movement. Can we go to the next slide, please? Okay, perfect. Thank you. Okay, we'll talk about that mapping out of the movement. For each of these branches that I just told you about, in emergency medicine, in disaster medicine, we talk about the 4 S's of emergency preparedness and response. This is staff, structure, system. Next slide, please. Staff, of course, is we know it's the people that's actually doing the work, right? And what you want to do is you want to look at your current situation. What is happening now? Okay, we don't have any VHF cases in our country. So So just having our normal staff in the hospitals at our fields, that's okay. We can deal with that. But what happens then if we get 10 patients because they were doing mining in DRC and they came back to your country? So you need to plan for the worst situation and think about your processes. What are you going to do? Your standard operating procedures. Is that in place? Is everyone trained on it? Do you need a memorandum of understanding? Let's say from the public health sector with private of saying, if we run out of space, private, please, can you come and assist us? We can't plan these things when we are in the emergency. So we want to do it before. So we want to do it now. Looking at your procurement, I was saying that we can't wait for 3 weeks if we need something. So how can we fast track it? And all of the logistics that is needed. Next slide, please. So of course, staff, as I mentioned, this is the people who actually does the work. Stuff is the equipment. This is all of your medical equipment, epidemiological equipment. We need internet, we need laptops, we need our personal protective equipment, all of the resources that you need. This is stuff and it needs to be planned for. Now, structures is like a physical infrastructure, facilities. Do we have hospitals? Do we have Ebola treatment units? If we don't, how can we get things or something to put up the treatment unit? And then systems. Again, I want to emphasize this. Systems is so important. You want this down to the T before the emergency starts. You don't want to run around when you have an Ebola case. You want to know now, okay, I have a case, I'm going to phone my director. Then I'm going to phone my contact tracing lead and my case management lead. I'm going to activate my INT immediately. Everyone knows what are the steps, what they need to do. Next step, please, Faith. Next slide, sorry, not step. Next slide, please. Okay, so as I mentioned, what helps me is I want you to use your imagination. Sit with your team and map the movements of your patients, right? Your potential and person under investigation. So does it start in the community? From the community, would they directly go to the hospital or would they go through to a primary healthcare clinic first? What happens if they don't go to a treatment facility and they die? What procedures do we have in place to actually get notified of these deaths in the community? Do we have burial teams to come in and remove the body? Do we have enough burial sites? Next slide, please, Faith. So the next few slides is just me trying to explain what I mean by mapping the movement, right? So I am in South Africa, right? So I have a patient coming from the DRC, coming to Cape Town International Airport. We fall under our point of entry of Port Health branch, we put in screening. But what I want you to do is to detail how are you doing the screening? Is it electronic? Are you doing just fever screening? Who is checking these forms? Do you have enough port officials checking screening and checking the tools? And then what happens if this person screens positive? Okay, this person is symptomatic. He was in DRC in Itiru. Okay, what do we do now? Do we have an isolation room at our point of entry? Do I have an isolation room where I can put this patient while we wait for the EMS and the infectious disease specialist? Or do we have an ambulance on standby all the time and we can just put them in the ambulance? But do we have EMS in our INT? Are the EMS people trained? Do they have PPE? Who do we inform? Who should we phone? Where will they be transported? Do we have a special ambulance? Do we use a normal ambulance? How do we clean the ambulance afterwards? Who's responsible? Are we taking this patient to a hospital? Do we have a specific hospital? In the hospital, do they have all of the things? So next slide, please, Faith. The other scenario that could happen is the person enters into through our point of entry into our country. No symptoms, asymptomatic, still in the incubation period. But then they start to get sick in the community. So what processes do we have in the community? Do we have community-based surveillance? Do we have community health workers? And then if they get sick, where will this person go? Will they go directly to the hospital because that they are so sick, they're just keeping everything going to the hospital? Will they go to a primary healthcare clinic? Will they go to a traditional health practitioner? Will they go to a herbalist or a chemist or anyone like this? And then if we know our community makes use of herbalists and chemists, did we talk to them? Would they report it to us? Do they know the signs and symptoms? Do they have PPE? And how do we follow up? Next slide, please. And then this is just the same again, thinking about, okay, now this person is in hospital. Again, I want you to think through all of these steps. Okay, what are our processes at the emergency department unit? How will this patient be transported? Do they have an isolation unit? Do we have, again, PPE? Do we have infectious disease specialists? Do we have equipment to take care of this patient? If this patient deteriorates and go to the ICU, and if they die, what are our steps? So literally think about all of the movements from like entry into the country up until, they're discharged or they pass away and we need to bury them. And is our mortuary attendants and our funeral practitioners, are they trained? Do they have the PPE? Will they let us know? What is the process again? Next step, please. Next slide. Sorry, I'm stuck on steps. Next slide, please, Faith. So that was a mouthful, but what I want you, just my parting thoughts, what I want you to really do is, I know it is traumatic. A lot of us went through COVID-19 and a lot of us struggled and we lost people. But we really do need to learn from the previous outbreaks and from the COVID-19 pandemic. We can't have pandemic amnesia. Prof. Lucille Bloomberg from South Africa always says, never let a good outbreak go to waste. There's a lot of good things that happen. There are a lot of opportunities where we can improve. So let's go back. We do our after action review, and we try and see where we can improve. Don't rely on magical thinking. If you put it in the guidelines, if you say that, okay, I want contact tracing to be done for all of the cases, you can't stop it there. You need to do the 4 Ws. You need to say, who is going to do the contact tracing? When is it going to happen? Is this every day? Are we doing just fever screening? Are we asking for all of the symptoms? Are we phoning them? Do we have the cell phones or the phones to do it? Do we have their numbers? How are we going to do it? How is so important. We think about health system strengthening. Of course, we want to do a health system strengthening. One of the most important ways of mitigating and mitigating health emergencies. Make sure that essential services are ongoing. Focus on your immunization program. Focus on your chronic diseases and other infectious diseases. We don't want a measles outbreak on top of Ebola outbreak. And we have seen our immunization rates declining during COVID-19. And now a lot of the countries are having outbreaks of vaccine preventable diseases. So, and just because the big is happening doesn't mean the small stop. And we still need people to continue with the small. And please do not forget about our vulnerable populations and the people living with disabilities. They often get left behind during health emergencies. And then last slide, please, Faith. And that is everything from me. And remember, in public health, we do not panic. What we do is we prepare. We do have a heads up. So let's make use of that. Thanks, everyone. That's everything from me.
Wow, a big thank you to our speaker. That was a beautiful presentation. Please let's show some love to her. Use the emoji to appreciate her. Thank you very, very much. We greatly appreciate you. That was a beautiful presentation. I think one of the key message that stands out for me is a reminder that preparedness must be seen as a long-term investment rather than waiting for the outbreak to occur. We should prepare ahead. And you also emphasize that a strong coordination system is needed for country to continuously learn from past outbreaks. So thank you so much for that. And you also showed us the map individuals for potential movement and different scenarios to identify risk, opportunities, and stakeholders. That was beautiful. Thank you very, very much once again. Please let's show some love to our speaker again. That was a beautiful presentation. Right now, we'll be moving on to the next speaker for the day. And our next speaker is going to go deep into disease surveillance and outbreak investigation. Please join me in welcoming Dr. Kleso Munjane. He's a physician researcher at the National Institute of Health, Mozambique, and the former head of the Department of Surveillance and Surveys and Outbreak Investigation. He's a distinguished medical doctor, a clinical epidemiologist, and a public health leader from Mozambique. He currently serves as the head of Department of Health Surveys and Observation and the general coordinator for SIS-COVE, that's the Community Health and Vital Event Surveillance Systems at the National Institute of Health and in Mozambique. With an extensive background in field epidemiology, Dr. Munjane directs national community-based health surveillance, outbreak investigations, and demographic health surveys for Mozambique Ministry of Health. His career centers on strengthening local health architectures through operational excellence, helping transition national mortality, tracking models into robust early warning networks capable of catching epidemic threats. He's an active global researcher. His academic collaborations span the Johns Hopkins Broomhead School of Public Health and the Liverpool School of Tropical Medicine. His recent landmark research leverages cutting-edge multiplexed serological surveillance to track multi-pathogen vulnerabilities, population immunity gaps, and real-time disease transmission patterns, providing critical data to steer proactive pandemic preparedness strategies. Thank you very much, Dr. Munjane, for the opportunity to speak. And he will be speaking on strengthening public health surveillance and early warning systems for early detection of infectious disease threats in Africa. Thank you once again, and over to you.
Thank you, Faith, for inviting me. So my name is Salso Monjane. I know it's a little bit difficult because it's Portuguese, but it's Salso Monjane from Mozambique as well. And today I will be sharing some reflections with you and let me share my slides. So, please, can you see my slide?
Yes, we can.
Sharing my some reflections on strengthening public health surveillance and early warning system to detect infectious disease and outbreak. So some of topics may be overlapped with Jenny presentations. But I will be focusing in terms of examples from Mozambique that we've been using to face outbreaks here. So I'm sorry, I will turn off my camera to improve the better connection and avoid issues. I'm sorry about that. So the African region has experienced a number of infectious disease outbreaks over the past 2 decades. We can see mostly between 20,000 or 2001 and 2022. We faced around 1,800 in terms of public health emergencies. And when we look in terms of the timing, we can see that it has been increasing in terms of the number. If we look to the time between 2001 and 2011, the number has been increasing. But if we compare with what happened after 2015, from 2015 and 2022, we can see that the number tends to increase more. Most of these cases, cholera, Ebola, measles, and of course, COVID-19, we faced it in 2020 and 2021. And this has been increasing and mostly looking to emerging infections. In most of the case, we talk about zoonotic disease, which remain major public health challenge, showing that around 63% of that increase in terms of zoonotic disease. And we cannot look at human health and isolation, of course. We need a kind of one health approach which integrates human health, animal health, and environmental preservations. And most of the challenges are actually starting from our acts of what we do usually. Deforestation, climate change, and the urban expansion are the most operating, which bring us close and more close to animal reservoirs of the disease. So that's why we're facing more of that coming from the animal and then infect people. In Mozambique, in the last 2 years, 2025, and actually also 2024, 2025, and actually 2026, we've been facing a lot of waves in terms of cholera outbreaks, as well as Mpox that we faced last year. And I will be talking about it in one of my next slide. But Sub-Saharan Africa mostly buried the highest number in terms of the morbidity and mortality associated with disease outbreaks. Most of the challenges are actually with the quick population growth, which we have been seeing in most of African countries, the urbanization and the insufficiency in terms of funding for emergency preparedness. But in most of our contexts, we also face challenges related to climate change and increasing in terms of international mobility. But one of the social things that we have been facing, and it's actually in our eye, but it's very difficult to solve, is related to misinformation, which is very, very dangerous for us. And we have most of the time difficult to solve the problem, even knowing the biological measures to solve and to catch the transmission of the disease. But it has been difficult because of misinformation. And now with social network and so on, the information spread very fast, and it's very fast when we talk about misinformation than when the information is true. So to achieve timely outbreak detection, we need to address not only the funding issue or the funding shortage, but also the compounding pressure of urbanization, climate events, and also misinformation as been talking. Socioeconomic environmental and financial challenges remain most of the critical bottlenecks in our situation, which limit our capacity for earlier infection, disease, and detection. But we have to look in terms of challenge and see how we can improve that to get solutions. So transforming public health challenges into solution, it needs multi-level intervention, not only looking for one level. So we have to talk about individual level, we have to talk about community level and the health system level. But knowing that both are connected. We can't talk about health system without community level, and we know that the community level is actually in terms of the blocks, we need individual level. So these three levels do not operate separately. They need to act together. We can't expect that health system perform better or effective in disease surveillance when local community lack the training or report in terms of ill alert, but also the community capacity depends on improving individual literacy. So we see in terms of food security at individual level, the basic livelihood, and so on. So we have to know that these three levels need to be connected, and we can't talk about only one level without looking to what happens in other level. The laboratory level, it's also a chain. When we look what happened in the nowadays, mostly the recent year, we have been talking about improving in terms of laboratory surveillance. We talk about, for example, genomic surveillance, but we can't talk about genomic surveillance if we can't talk about the others. So this is a cycle where strengthening the diagnostic lab needs to improve in terms of access to lab equipment, to enhance in terms of specimen collection. So we have to improve in terms of method we use for specimen collection, for transport and the lab chain, and so on. Then expand to genomic sequencing and capacity for pathogen identification. And after that, we talk about strengthening lab data sharing. But we know that this is a cycle. So if we strengthen in terms of lab data sharing, we can also have in terms of strengthening the results, strengthening the laboratory diagnostic and network. So these have to be treated in accordance together and not just looking to one level. From our experience in Mozambique in 2025, we have been facing one of the major wave in terms of outbreak of Mpox from 10 July 2025 to October 2025, where most of cases were located in only one province from Mozambique, which is in the top region, in the northern region of Mozambique. And around 89 confirmed cases were identified. From that, 79 were coming from that province, call it Nyasa. So you can see we rolled out 4 provinces, but from the 89 cases, 79 were identified only in one province. So we didn't have any deaths, of course, but the collaboration with other authority and the multi-level collaboration helped us in terms of containing this outbreak to only one province, and without spreading for other provinces which are close to that. And this has to be the most of the main goal when we want to contain and cut the transmission of the outbreaks. So how we responded, we developed, or we tried to plan different level in terms of coordination, where we had general coordination being done at high level in the Ministry of Health, of course, including National Public health, of course. So this was the most strategic aspect to respond of the outbreak, which tried to optimize in terms of response time by bringing community level reporting with decentralized provincial testing, and we can catch and confirm outbreak locally before they reach at a national scale or even spreading to other countries and provinces that we are close to Tunisia, while at a central level, in this case, MOH and INS try to ensure overall strategic alignment and cross-border cooperation protects our merging. Of course, we discussed it a lot when we had at the first time the identified the first cases, because this was coming from a region that is very close to other two countries that are neighbor to Mozambique, and it was difficult to control because it was very remote area and very far from the city, and even from the nation or from the capital of province, and of course from of the country. So we had to plan the collaboration with other countries across and close to the province. So in this case, we talked to authorities from Malawi and Tanzania, which also share the border, so that we can act together and try to improve to cut the transmission of the disease. So we face the challenges, of course, the difficult in terms of keeping effective cross-border surveillance at the point of entry, and we know it's not easy way to control issue about borders transmission in our context. In most of African countries, of course, it's not only from Mozambique, because of higher population mobility, and we don't know exactly which line they usually use. Our border are very porous. Know about that. We don't have any kind of wall that separate the countries, so it's really difficult to control. But discussing with neighboring countries and sharing its experience, cooperating with them, we could at least have successful results containing the outbreak only to one region. The other issue we face, this is not only when we talk about Mpox. You can recall even going back to the COVID-19 time, and we also face the same challenge. We talk about cholera and others. Is the low public health acceptance when we talk about mainly home isolation. No one accepts that. So because most of time they will come with the question that where should I get something to eat? Where should I get something to give my children, and so on. So most of them, even receiving the information that need to be isolated, they still walk around, and then we have this challenge at the end. But one of the main points when we talk about surveillance and outbreak responses, our capacity in terms of detecting in a real time, or at least in a short time, the transmission of the outbreak, and then try to act at the local level and block it. So some of example that we've been using, and especially in cholera outbreaks in Mozambique, is called COMSA, which is Community Surveillance System, or COMSA SysCoV, in Mozambique. And we know this kind of as sample registration system are also being implemented in other countries, and some of them that can be used to control. So the team tried to monitor the cases of diarrhea in all of countries, so in the cluster that the system is being implemented, and also death from cholera, so that in a short time they can inform for the public health health action. So this is the map of Mozambique with the areas inside showing the results of the data collection for the community surveillance agent. in those areas where they collect and share continuously with the highest level so that this information can be used to know where at least the cases of diarrhea and death from diarrhea are coming from, and that the solution or at least the measure can be developed and go back to that place. So this is one of the examples that can be used in most of African countries to detect in a short time the outbreak and also act on that. The second example I wanted to share with you is related to the field in epidemiology training practitioner, which also helped us in most of emergencies. And actually, this slide is coming from the emergency that the country faced in the beginning of 2026, responding to floods in the southern region of Mozambique, where the FATP or the FATP were called to respond to emergency at the local level. So they were part of the team that went to accommodation center to collect the data and then inform and populate the public health bulletin, which we are using to monitor the situation and how to design the public health measure to stop and solve that problem. So in terms of coordination and active surveillance of priority disease and investigation of error, this team is trained to collect this information in real time and also share it in a short time. So this is one of the example that we have been using in Mozambique and can be also used through in other countries. This is a busy slide, but I just wanted to show you, of course, I know I see one of slides from the last presenter showing the similar, but just to show, we have the main pillars for the outbreak preparedness and response. But we have to note that the strong coordination between the different levels, the multi-sectorial collaboration and community participation is very important to achieve the results. We can't get any successful results only looking, for example, for surveillance and early detection, looking for laboratory diagnosis or clinical management. We need to coordinate and try to improve all of these pillars. So our goal, of course, is early detection in terms of and effective response and reduce impact of outbreak. But we need to improve the surveillance system and early detection. We need governance to support even for the laboratory diagnosis and fund equipment for the lab, while community engagement drives the public to accept the vaccine, for example, or seek in terms of early isolation, which I talked about, and achieve our goal, which requires the total synchronized between clinical community and admin sectors. So, well, I'm going to the end in terms of recommendations. We think that it's important to invest in terms of early detection and outbreak prevention system, but also strengthen integrated surveillance, lab, and genomic surveillance capacity, and also promote multi-sectorial and cross-border collaboration for health security in Africa, while expanding workforce development and community engagement to support the surveillance and response effort, and increasing sustainable funding for public health preparedness and response. So this is my last slide for today. And again, thank you for the space following that.
Thank you, Dr. Monte. I apologize if I pronounced that wrongly. Thank you very much for that beautiful presentation. Please let's celebrate him, show some love, appreciate our speaker. Thank you very much for that amazing presentation. We are very grateful. And I think you've passed an important message that effective outbreak preparedness begins with strong surveillance system. And that is what we can use to detect threats early before they evolve into large-scale emergency. And we like the fact that you use Mozambique experience to demonstrate the importance of community-based surveillance, giving us several examples, laboratory capacities and cross-border collaboration in strengthening health security across Africa. Thank you once again. We are very grateful. And thank you for accepting to be a speaker for this webinar. Right now, we'll be moving on to the third speaker for the day. It's our pleasure to introduce Ms. Sadaf Lanes, Director of Collaborative Surveillance, Workforce and Health Emergency at IAN PHI. Ms. Sadaf is a broad-level health system expert with leadership experience across public health, integrated healthcare systems, and translational research and innovation, implementing evidence-based health outcomes from prevention to value-based healthcare. She has experience working in the UK, Middle East, and internationally teaches on a UK Roswell Group Masters in Public Health program. She is a member of the UK Faculty of Public Health and Fellow at the UK Royal Society of Public Health. She would be speaking on strengthening health system preparedness, building workforce capacity, and emergency coordination for infectious disease response. We are so glad to have you, Ms. Sadaf. Thank you very much, and over to you.
Thank you very much, and thank you for that wonderful introduction as well. And I'll try my best to do a good enough job following such wonderful two presenters that we've just heard from. Faith, do I share my own slides? Shall I do that?
Yes, please share your slides. Thank you.
Okay, great, fantastic. So let me do that. I hope you can see my slides. I'll go right to the beginning.
Absolutely, we can.
Okay, that's wonderful. Thank you very much. So, yes, as Faith introduced me, I work for an organization. It's an association, it's an NGO, and it's the International Association for National Public Health Institutes. So the members that we have as part of IANFI are all MPHIs. I saw a question referring to, do we need public health institutes or do we need national centers for disease control? And actually, within our membership, we have both. It's really just a name. So some organizations call themselves MPHIs. Some organizations call themselves public health agencies. Some call themselves disease control centers. What is really important is the functions, the roles and functions within those organizations in terms of health emergency preparedness and response systems. And some of them will also have non-communicable diseases as part of their remit and their mandates. But the mandates are set by government. MPHIs or CDCs report to government, but they are semi-autonomous in the way that they provide scientific advice to the governments in terms of policies, in terms of how to actually respond to outbreaks. And they have an active role in terms of coordinating responses as well. So my talk is going to be a bit about the work that IANFI is doing. And you heard from the first speaker, Janine. She is also actively part of this work that we are doing. So I'm really pleased to see her on this session. So I'm going to introduce a concept that was developed by the WHO a couple of years ago. Oh, Faith, I'm trying to... Well, I can move it forward. Okay, great, fantastic. It's called the Global Health Emergency Corps. And this was introduced by the WHO a couple of years ago, which is, you can see this pyramid. And the concept of this is based on the HEPA framework that Janine introduced, the 5 Cs. And it's about how do we manage our public health workforce or health emergency workforce during a health emergency. And it was looking at that time on the global system and the network. So you've got GORN, you've got EMT, you've got AVOC Surge, you've got Africa CDC, all of these organizations that play a role within health emergencies. And so we were invited to be a partner on that work. And my first question was, we're looking at global, regional, but we actually need to look at those domains and apply them into our national country context settings. If we don't strengthen our country context settings, then, we are relying all the time on the regional and the global networks. And really, we should be coordinating national, subnational, and community level mechanisms first. And so that was the work that we decided to do, and we were fortunate to get a Gates Award to help and support us with that. But the GHEC framework is around how do you rapidly respond and surge your workforce. And then it was also around what kind of surge capacities are required to support your public health workforce. And that you see at the top of this is the connected leaders. And connected leaders are those people who bring together and are able to provide our operational teams with the enablers, the levers, the kind of, resources that are required to really respond to health emergencies. So what we first did was that we looked at the role of national public health organizations in health emergencies, and we conducted a survey. We also interviewed leaders who were chief executives or DGs of MPHIs to see what their perspective was on their role within a national setting during a health emergency. What was interesting to us was that we also examined what do they do before a health emergency to make sure that the health system is resilient, and that their role is also about connecting across different sectors. So that whole of system, whole of government approach. How successful is that? And what kind of things have they been able to operationally put in place that has been, really useful for them from a governance perspective, from a coordinating perspective? We also wanted to see that linkage or the relationship between national to subnational and community level. So where is that community engagement? And from the Africa context, that was really important for us to examine that and then compare it across the other regions across the world to really understand that. So we saw that there was some multi-sectoral coordination and collaboration, yet it wasn't strengthened, it wasn't sustained during peacetime or non-health emergency time to be able to be optimized when there is a health emergency. So in health emergencies, there was also a coordination gap because there wasn't a clear understanding of structures in terms of roles and responsibilities and accountability as well. So there was quite a bit of overlap in terms of what the roles and responsibilities different organizations and agencies thought that they would be tasked to do during a health emergency. The One Health element was found to be weaker in health emergencies. And so that was an area that was really focused on in terms of improving that within a coordinating mechanism. And then the national, subnational, and community level, there wasn't clarity in terms of who is responsible for bridging those gaps, for strengthening those relationships, for engaging with civil society organizations, with community leaders, for example, to subnational public health EOCs. So there were, breaks that were visible that we could pick out from the survey and the interviews. And that real level of responsibility for who is responsible for engaging across different sectors, whether that's public sector, private sector, academic organizations, bringing them together. So who is responsible for the convening and discussions and decision makings? So we saw that there's a preparedness gap. And people jump into action when there is a health emergency, but they then start working with people that they have not had prior relationships with, but they have knowledge of. And also what we saw was that there's not a all hazards approach to health emergencies. So you have infectious diseases, but, as we know, there are more emergencies that are emerging at the moment that are not primarily infectious disease. And infectious disease might be a secondary cause. But then if that happens, what exactly is the role of a National Public Health Institute? How do they communicate and work across the health system as well? And so that there isn't clarity in those situations. So then we talked about the challenge of surge response. So how do you scale up? And one interesting aspect, and I'd be really interested to hear from the attendees, is the understanding between the difference of what rapid response is versus what surge response is. And sometimes we see that terms being used interchangeably. And in a lot of cases, there is a rapid response team that is, and you have incident management teams and those kind of things. But really, when you have a wider outbreak, an epidemic that threatens to be a pandemic, you have to very quickly surge your public health and your health emergency workforce. Yet, MPHIs, for example, if I look at it from that perspective, don't really know where that health emergency workforce sit. And MPHIs are different in terms of their governance and their structures across different countries. So health emergency workforce does not sit neatly underneath an MPHI. It sits across the health system. And so that bit of mapping is not there to understand, one, what roles are needed, two, where do those public health workforce sit or health emergency workforce sit, and how to deploy them in a timely way. So I think that was the challenge for us to look into. So we engaged 12 national public health institutes, and there's 5 from Africa: Sierra Leone, South Africa, Uganda, Kenya, and Mozambique. And we co-created and co-designed an approach which we're calling the AID model. So A is the ability to assess and forecast against epidemiological data what workforce is required. I is to identify and be able to pull in the staff that is required. And D is to prepare and successfully deploy and manage the surge staff as well. So we had 2 co-creation workshops, and the co-creation workshops were to explore these concepts of the AID model, but also the importance of connected leadership and the role that connected leadership plays. We had 1 workshop in Kenya and 1 workshop in Malaysia. And our Kenya National Public Health Institute hosted us in there, and the Ministry of Health in Malaysia hosted us in Kuala Lumpur. So you can see the attendees here. So the overarching question that we had for the workshop was, how should a future-ready, multi-sectoral, multi-level public health workforce system be structured and sustained by MPHIs to ensure rapid, scalable response to an all hazards health emergencies? And through 2 days of discussion, we went through the A and the I and the D, and we came up with a list of how we would approach this. And we especially looked at it not only from the national level, but as I said before, we drilled down to those connections between national operational and coordinating mechanisms, then to the sub-provincial level or the sub-level, national level, and then brought it down really into community levels. And we brought that into a loop as well to make sure that we really understood that it's not just a top-down approach, but it's a bottom-up approach. So that engagement piece was really important for us to understand in the AID model in terms of workforce and coordinated mechanisms. And within the connected leaders group, so we had the leaders of the MPHIs there, we were really focusing on their role for strengthening preparedness and response systems. So within that, we also looked at cross-border, regional, multi-stakeholder. How do you engage professional associations and academia, civil society organizations, primary care centers that are really an overlooked resource? We always feel that, right? Because everybody thinks about healthcare, they look at hospitals, and primary care actually is the front door of how you can detect an outbreak early. So we were looking at how do you strengthen that? How do you then build that coordination and those networks and sustain them as well during peacetime so that they can very easily be activated during a health emergency. So when we developed the AID model, we wanted to test it. And so just last month, we undertook an exercise, a simulation exercise. Janine was there as well, helping with this. And it was called Exercise Capricorn. And the National Public Health Institute of Kenya volunteered to test this AID model. And when we designed the simulation exercise, they were not aware of what we were going to be presenting them with. And we wanted to really do this and test it out from a multi-stakeholder perspective as much as we could, bring different stakeholders together in the room. So we wanted to look at the triggers for assessment and activation of surge workforce. How would you know where your surge workforce actually sits? What level of triggers do you need to activate different workforce within different professions, skills and expertise in organizations? So then what information do you need? And we were talking about, surveillance. We did some work around integrated disease surveillance, but it's also about collaborative surveillance, because sometimes you don't have the platforms to be able to bring all the intelligence together at the same time. So collaborative surveillance is really important to build those relationships so you receive additional information and intelligence that you need to make those decisions as well, and how you translate data into intelligence that you can provide to decision makers. So we wanted to look at the concept of connected leaders. At what point are those connected leaders important? At what point do you bring them together to have those really important conversations as well? So what we wanted to achieve from this is, one, the benefits to the Kenya National Public Health Institute in terms of how they can strengthen their AID model, how they can strengthen surge deployment as well within their country. So you can see the participants were from the county level, we had the national level, multi-sectoral. We also had invited external, which included the WHO country office, AMREF, Red Cross. And we added cross-border as well. So the Ugandan Ministry of Health were there, and the Ugandan National Public Health Institute also attended this as well. And we asked, and you've probably all attended these tabletop simulation exercises, that everybody had to respond as though it was a real life situation happening. And we wanted to test the AID model at every point of the injects within the scenario planning. So this just slide, and Faith said that she will circulate the slides, but these were the scenario that we developed. And what was interesting was that actually in phase 3 or phase 2, what we also introduced was a different health disaster scenario. And we built a scenario of where there was a different there was flooding happening within that province or within the county that we were looking at, that actually tested the role of the National Public Health Institute and the role of emergency coordination across health systems. Because all of a sudden there was a pivot from a government perspective, and there was a reprioritization against the outbreak that we were looking at. So we looked at things like contingency planning. What would happen? How would you get the resources then? What role would you play if it affects your own public health workforce or health workforce because of the floods happening within that county? So we really challenged and tested the systems that were existing, and we examined on what could be approved or what could be improved, and identified those areas for improvement. So this is really some of the key operational gaps where we saw there were delayed technical actions which happened. There were some other things around policy and resource, and not being very clear around when to engage different stakeholders in the discussions, and also who was responsible for what. And where do you then rely on external agencies to come in and support you with some of those responses? So this is just to show what the revised AID model now looks like, because one of the areas that we thought really needed to be strengthened was the area of connected leaders. It was felt that there were quite a few gaps, even in the way that we manage coordinating mechanisms at the moment, and the way we bring our leaders in for decision making and to be able to provide the resources that are needed in a timely way. And so we thought health actors, we talk about health system resilience, but health system is really, really broad. There are lots of actors, stakeholders within that. So we need to ensure a clarity of what their roles and responsibilities, and the accountability structures as well. Who's accountable, who's going to hold these organizations accountable as well during a health emergency. We need to ensure that engagement happens in advance of any health emergency, and there are mechanisms in place to develop professional relationships and perspectives, and that includes, multi-sectoral exercises as well. It includes learning from other sectors and adopting and adapting according to the multi-sectoral engagement and the discussions that you have. It's also about language and communication. Often enough, we speak very scientifically to others, yet others have different languages, professional language that they use, right? So it's about understanding priorities that others have and being able to translate scientific information into language that is not only comprehensible, but the impact of inaction is also understandable as well. And I think that's something that's really important when we are looking to mobilize or pool resources, and we're looking to engage stakeholders as well in terms of planning the way that we would manage an outbreak or a health emergency. So in terms of taking those learnings into actions, early stakeholder engagement, clear roles, I've just spoken about that. So ensuring the resilience of sub-national facilities like primary care. So we need to engage, primary care, we lean a lot on primary care as well, yet we don't make the primary care facilities resilient for a health emergency. We just expect the adoption will happen, but we need to bring them along with us in terms of planning for outbreaks. Contingency planning should be agreed in advance. The what-if situations or scenarios should be actively discussed, and then it should be agreed what would you do in the case of workforce changes, for example, deployment changes which are required, impact of different aspects that might impact the way that you pool your resources and use your resources, and workforce are how they deployed. And then to ensure well in advance that you have the policies, you've got the agreements in place. If you're pulling people out from different organizations, how would they be backfilled? Who is supposed to be financing them? How long can they be deployed from? All of these aspects need to be agreed beforehand. And then running those workforce exercises and training, which are multi-sectoral. We're not there yet. I mean, we go to so many meetings, we have so many discussions, and a lot of times it's like an echo chamber because we're all agreeing on the same thing. We're all having these exercises with the same people. And actually, we need to bring in other sectors into the simulation exercises, into these discussions, so that there is a common understanding and a common language that is being developed, and agreements are being developed in conjunction with these different sectors that we want to engage during a health emergency. So the work that we've developed now will be moving forward, and we want to engage with a wider audience in terms of socializing and supporting different national public health institutes as well. And one of the things that we've just established under IAMFI is what we're calling the Public Health Emergency Alliance of Leaders of FEEL. So this is a member-driven convening of directors of health emergencies. We've just had our first meeting. And really, it is not a working group. It is not a committee. What it is a peer-to-peer group or meeting of directors and health emergency leads to talk about challenges and areas of concern and opportunity, and to share best practice with each other. That's it. That is really what the purpose of that group is. And it's about how we can support each other, which is why it's peer-to-peer. So we had a really great meeting. The first meeting, we discussed and agreed what the purpose was. And our colleagues from Uganda gave a presentation on Ebola outbreak. And it wasn't from the clinical perspective. It wasn't from the epidemiological perspective. It was from the system strengthening perspective. So what kind of aspects within their system has been useful that they've been working on for the previous years? It can be governance, it can be financing mechanisms that really helped them during this Ebola outbreak. And what kind of partners were they dependent on and leaning upon to really help them in terms of tackling the Ebola outbreak? So we also work with Africa CDC on the Pandemic Fund Award as a delivery partner. We'll be moving forward with that. And as you know, Africa CDC has a framework that all countries, member states across Africa should have a National Public Health Institute. So we're supporting them in terms of the maturity assessment framework for National Public Health Institutes. Our collaboration with WHO includes the core competencies for MPHIs in health emergencies, and we want to expand that, which we will be doing over the next couple of years in terms of direct engagement with countries based on the work that I've just been speaking about. And I'm really pleased that Kai is here today to speak to you all about this really fundamental, important piece of work, which is around community engagement. We all know that communities are where outbreaks happen. And yet we cannot have a national down to subnational, down to community level approach. We really need to start with communities. And so that engagement piece, strengthening, is very important. It's fundamental. That's where we need to start with. And so we are 100% supportive of that. And we are examining the role of National Public Health Institutes and how they can start engaging with the communities as well, and building that level of confidence and building that level of trust as well in aspects that will support us in outbreaks in the future. So I just wanted to put this quote here, which, you all are aware of. If you want to go fast, go alone. If you want to go far, go together. Thank you. Faith, back to you.
That was a beautiful presentation. Thank you very much. Please let's appreciate our speaker. That was very, very beautiful and quite elaborate. So thank you very much for your presentation. You strongly highlighted that health emergency preparedness goes beyond only infrastructure. It requires a well-prepared workforce from a strong leadership, clear coordination mechanism, and it allows countries to respond effectively during a pandemic. And you emphasized that we should have a system right from the community level, which is where the outbreaks happen. So thank you very much. Those insights were really, really valuable. So why workforce pandemic preparedness and emergency coordination remains essential at the national level? So strengthening health security is also required, particularly at the community and regional level. And this, like our last speaker mentioned, and this brings us to our next speaker for the day from World Health Organization Emergencies Program. Please join me in welcoming Dr. Kai, the Unit Head of Community Protection and Resilience, World Health Organization Health Emergency Program. You're welcome, and I'll be reading his biography briefly. Dr. Kai is the Unit Head for Community Protection and Resilience at WHO headquarters. He leads the work on the HEPR Community Protection Subsystem. With over 15 years of experience in health emergency preparedness and response, he has spent the past decade working in various capacities within the WHO Health Emergency Program across all 3 organizational levels and in 3 different regions. He served as the head of WHO Emergency Sub-Office in Cox's Bazar, Bangladesh, where he led the health response to both Rohingya crisis and the COVID-19 pandemic in the world's largest refugee camp. And before joining WHO, he served as a surgical resident at Yale University of Medicine, a research fellow at Mount Sinai Medical Center, and for the German Red Cross in emergency medical services. Kai holds a medical degree from Hamburg University and a master's in disaster management from Copenhagen University. And he would be speaking on advancing regional health security in Africa, community resilience, and cross-border collaboration for future infectious disease threats. Thank you very much, Dr. Kai, for accepting our invitation despite your busy schedule. We are glad to have you here. Over to you.
Yeah, thank you. Thank you very much, Faith. And also thank you to Get for the invitation to speak, and also to Sada for her kind words before, and all the previous speakers. As Faith mentioned, my name is Kai van Habu. I'm the Unit Head for Community Protection and Resilience here in WHO headquarters in the Health Emergencies Program in the Department for Health Emergency Preparedness. And I'm also leading the community protection pillar of the Ebola Incident Management Support Team here at WHO headquarters for the current Bundibunja outbreak that was mentioned already many times. And I can speak a little bit how we apply and operationalize community protection also in that context in this brief introduction and update on our global efforts to advance this important topic of community protection within health emergency management that was already mentioned a few times. And I think as was also mentioned already earlier in the presentation, we have, as WHO, we have introduced a new architecture for health emergency prevention, preparedness, response, and resilience, or HEPR, called the HEPA framework. And that consists of these 5 C's that you see here on the right. So emergency coordination, collaborative surveillance, access to countermeasures, safe and scalable care, and community protection. So this is really, I think, a paradigm shift for our organization, as we have elevated community protection to that level. And I will talk a little bit, of course, what we talk about here when we talk about community protection. And of course, this is based on lesson learned from the COVID pandemic in particular that informed this new architecture, but also many other health emergencies in the recent past that really again and again showed similar challenges, including factors around low trust in institutions, unequal access to information and services, etc. So all of these we are trying to address with this community protection approach. And that applies as an all-hazard approach to protracted emergencies, fragile settings, and of course, outbreaks as well. And I think this is, of course, even more relevant today with the new reality that we are facing with lack of sustainable funding, decreased availability of external aid, etc. There's a very important kind of reasons to also focus on resilience building and community capacities. And as part of community protection, we have developed jointly with UNICEF and IFRC, who are important partner for us in this area in particular. This framework called Defining Community Protection that you see here on the slide, which is really about putting communities at the center for preparedness, response, and long-term resilience building. And this approach is really structured around 3 objectives that you can see here on the slide: risk communication, community engagement, and infodemic management. Of course, a very important aspect in the response to every emergency and outbreak in particular, but also any other emergency. It's really about enabling communities to make informed decisions, to know about the risks they are facing in a health emergency, and also about engaging communities in decision making in a meaningful way to ensure that they are accepting our public health advice and really adopting protective behaviors. And of course, a very important aspect here is trust that was mentioned already as well by some of the colleagues, and we will talk a bit about that. And of course, this is not just about telling people what to do. It's about listening to communities, then adapting the response so that that we are responding with the communities and not imposing our decisions on them. And this is really critical to be done and started in the preparedness phase, not in the response to an emergency, because we don't build trust in the middle of a response. It's very, very difficult to do that. It has to be established and maintained through a continuous and long-term process. That's what we are really advocating for. And the second objective is called population and environmental public health interventions. And that's really to make sure that activities are context aware, locally feasible, socially acceptable. And here we put a lot of emphasis again on our kind of on the recognition that community members are not passive recipients of aid. They are active agents in every response. They are the first responders in every emergency, and also the ones that usually are still present when the international community has moved on to the next emergency. So it's really about how can we support and enable those local solutions, the self-organization of communities, the local resources, etc. So that's what this approach is about. And here, civil society is a very important aspect that was mentioned already before as well, also in the Ebola response, but also, for example, community health workers is an area that we focus on a lot, and other local actors. And then the third objective is called multi-sectoral action for social and economic protection. And I think Celso spoke to that already very well in his presentation. So this is really about looking beyond the health needs of affected communities, recognizing that socioeconomic priorities of vulnerable populations have to be considered, especially in settings like we have now in DRC, but also many other countries in humanitarian settings, but also any other setting when we look at particularly the vulnerable populations that are typically most affected by an emergency, and that we really have to put the most emphasis on in any kind of emergency. So we really have to see how can we ensure that communities are not losing their home or their livelihood when they go to a treatment facility, for example. So, to ensure that they are actually complying with these public health measures. So that these are aspects that we are addressing under this objective. And again, and of course, as well, secondary impacts of health emergencies, but also of the response measures. For example, school closures. I think everyone has a memory of that impact during COVID, but it's also relevant in many other emergencies on a bit more local level. And all of this goes well beyond the health sector. That's why we are putting that emphasis on the multi-sectoral coordination mechanisms here. But health has to be in the driving seat and actively coordinate those aspects with other sectors. And this is really an integrated model that we're presenting here. So these are the three objectives of the community protection framework and I will talk a little bit how all three of these are implemented in the Ebola response, because each of them is a critical component of any response to health emergencies, but also has to be again applied and implemented in the already in the preparedness phase. And this to apply this approach in a response was really established in the Mpox public health emergency of international concern, which was our last phase before the current Ebola Bundibujo response, where we really have established community protection as a response pillar in the IMST, and then have implemented across the different aspects of the three objectives activities that you can see here on the screen for this Mpox response. And following Mpox, we really applied this in every other major response. That includes Ebola and Marburg in Uganda and DRC, earthquake response in Myanmar, cholera IMSTs that were for the global situation, but also the Iran and Lebanon crisis, and now, of course, the Ebola response. And I'm sure that many of you have heard our Director General, Dr. Tedros, and also our Executive Director, Dr. Chikwe, and many other leaders in the current response, how much they emphasize this importance of placing people and communities at the center of preparedness and response efforts. And again, this is a lesson from every prior Ebola outbreak. That in particular, Ebola is so the community component, engaging communities, is so relevant for the outcome of our response measures, even more than many other emergencies. That's really a lesson learned. I think that all of us are aware of, and this is why we have established community protection as a key pillar in the IMST. And you can see here what we actually, these 5 core areas that we are including under community protection. Of course, risk communication, community engagement, again, really about helping people understand the risks and take actions to protect themselves and their families. Then public health measures at borders, points of entry, and mass gatherings. This is a very, very important component that was also mentioned already by some of the speakers to minimize the spread across travel routes and population movements, etc. Then readiness as a concept of really strengthening preparedness in a very operational way and with a very short timeline. So with a focus, of course, on those countries that are most at risk, the neighboring countries where we can anticipate importation of more than individual cases. So that's a really important aspect where we support countries in assessing their capacities and then identify gaps and then take anticipatory action ideally before cases occur or when there's limited number of cases. So that's a very important component that can talk a bit about as well. It's really the operational side of emergency preparedness. And it's under community protection in our IMST here. And then the fourth one is safe and dignified burials. Again, we have heard about that already. It's really about preventing infection during funerals while respecting cultural and religious practices. And fifth, operational and social science research is a very important component of this as well, ensuring that community needs and concerns and capacities and expectations are at the center of the response efforts. So this is really becoming a very well-structured and operationalized pillar with very clear interventions, with strong partnerships, and a direct link between response and preparedness strengthening. And this slide really summarizes the package of support that we are recommending countries to put in place under community protection across preparedness and response. And I won't have time to go through this one by one, but I just want to highlight three aspects here. Of course, RCCE is a backbone of community protection and really probably the most important intervention in an Ebola outbreak. It's about protective behavior. You will not, and especially this Ebola outbreak, but many others as well, through medical countermeasures. It's about changing the behavior of the population that they are aware of the context, and you have to do that with engaging with them, with the communities, ensuring that this is culturally sensitive and adapted to the local context. So that's really the key pillar. And here again, we are moving beyond message dissemination. That's very important, to disseminate messages and to reach everyone, but that's only the first step. And we really have to go beyond that, away from one-way information and awareness campaigns to the dialogue with the community and engaging with them, having them sit at the table and really hear the perspectives from the communities to identify how can we best approach and address challenges like stigma, discrimination, etc., that are very prevalent for many emergency and especially outbreaks, but many other emergencies as well, and in particular also in the Ebola response. And the second point I want to highlight here is the social economic effects again that I have mentioned already, protecting vulnerable groups, maintaining essential services that was already highlighted as well as very, very important. Oftentimes, mortality and morbidity from other causes is higher than from the Ebola outbreak itself. So focus on the maintenance of essential services is really, really relevant here, especially again for vulnerable groups. And here also, of course, gender sensitive approaches are really, really important. And then the last one I want to mention again, that readiness and community protection are very closely linked concepts. We cannot start with trust building during an outbreak. This has to be done. So community engagement has to start as one of the first readiness activities in those neighboring countries, and that's what we are really implementing right now in South Sudan, Burundi, Rwanda, all those countries that are at highest risk. And going back a bit to the broader community protection approach, as WHO, and in particular when working with those partners, UNICEF and IFRC, we are really a technical agency. We are the technical lead agency for this area, and we are really promoting an evidence-based approach. And this is really our complementary strength towards the other partners that are more implementation oriented and that have much bigger footprint than us at the field level. When you look at IFRC with their huge numbers of volunteers, etc. And here we are really we have published already a lot of guidance, and at the end of this presentation, I will share a link to our website where you can access all of these materials on a very structured approach and also a timely approach, because again, to generate evidence in the middle of a response is the timeliness factor is very, very important. So we have done we have published guidance on evidence. We have done a rapid assessment protocol, and all of these have been applied in Mpox, then in Ebola and DRC, and in cholera, and now again we are applying this, of course, at a very intense level in the Ebola response to the Bundi-Bujo virus. And what I already mentioned is our focus on community capacities. And here, of course, community health workers are for us a very, very important entry point. They are really the trusted partner of communities. They are the key link between the health system and the community, and a major provider of essential services in many settings. And they also play a key role in early detection and response to any outbreak, and really as a response to any type of emergency. But very often they or very few community health workers ever received a formal training in emergency preparedness and response. So this is one aspect that we are focusing on, where we have developed a competency framework for community health workers in health emergencies. that is currently being finalized, and we hope to publish this by the end of the year. So as a kind of normative approach, based on evidence, etc., and a kind of long-term project. And at the same time, we also applied already a training package in quite a number of emergencies, including now in the Ebola response that we have developed and that we are refining with every emergency. And we are now also moving towards trainings for preparedness, and have done that already in Zambia as part of pandemic fund activities for the first time. So this is another key area for us, focusing on strengthening the role and the capacities of community health workers. And another key partner, of course, are civil society organizations that Sadaf has highlighted as well. And of course, for us, also public health agencies to implement community protection are a key partner as well. Civil society organizations are really key partners also when it comes to trust, access to communities, etc. And we have developed this CSO framework for health emergencies that you can see on the bottom right, that provides a 10-step structured approach how to engage with CSOs in preparedness and response. And this is really directed mostly at member states, but also partners. And the last aspect I want to mention is that community health workers are a key interface between communities and the health system. But the other key interface at the front line is really the primary health care. And many countries have one or the other system, or both of them combined. And so this is the other aspect that we really focus on when strengthening capacities at the community level. And we have developed this emergency-ready primary healthcare approach together with Resolve to Save Lives. It's a very practical operational model to strengthen all hazard emergency preparedness at the PHC level, around four capacities that you can see here on the slide: connect, detect, protect, and treat. And we have published this following very intense internal and external expert consultations at the last World Health Assembly. And we are applying this again now in the Ebola response as well, in particular for readiness at the moment in Uganda, how to strengthen primary healthcare for Ebola detection, referral, etc. And of course, there's a very strong community engagement component in this as well. Again, this is a framework and an operational guide that has been published already and is accessible on our website. And of course, there's many other kind of materials that we have developed. We also have our webinar series called EpiWin that we are conducting every week. And we have already had a few of them around Bundibujo response, but also on many other aspects. But we also have a platform called Open WHO that is really for asynchronous information dissemination and trainings. And we have issued a training specific for Bundibujo virus there already as well, that you can see here on the slide. So I hope that you are able to disseminate this within your networks and your organizations, because of course there's a lot of interest right now in the Ebola response, and we are supporting the 2 affected countries, but also we are supporting a lot of the neighboring countries, in particular around readiness. But then there's another level that really every country needs to have a minimum kind of readiness actions implemented, because there is, of course, a risk of importation of individual cases to any country in the world at the moment through air traffic, etc. So it's very important that, and that, of course, generates also a lot of interest by our counterparts and the colleagues. So it's very important that we provide some training opportunities for those as well. So these are some of the materials that you can find also on our website. And here you can see, of course, we have our newsletter that you can sign up. We have our website, our Open WHO channel, and of course all the publications that I mentioned are accessible here as well. So I stop here. I'm happy to answer any questions. Thanks again for the invitation for this excellent webinar, and back to you, Faith.
Thank you very much. That was a beautiful presentation. Please let's appreciate our speaker. Let's use the emoji to appreciate him. Thank you. You can use the clap emoji, the love emoji. Thank you very much for that very insightful presentation. I think one key message that stood out for me is the reminder that effective outbreak preparedness cannot begin only when emergency occurs, but it requires a long-term investment and especially in building resilient communities, trusted local system, and preparedness capacity, even at the community level. And you also made emphasis on community protection, primary healthcare system, and the need to build a structure that allows community themselves to serve as the front line of health security and emergency response. Thank you once again, Dr. Kai, and sincere appreciation to all our distinguished speakers for their incredible, insightful presentations shared with us today. It has been amazing so far. Throughout this session, we've explored several critical dimensions of infectious disease, preparedness, response, from realities to ongoing outbreaks like Ebola to lessons, and to strengthening surveillance, early warning system, building workforce capacity for coordinated emergency action, and ultimately ensuring that communities themselves can remain central to preparedness and long-term health resilience. So at this point, we'll be moving on to the panel discussion, although we are running out of time and we'll be as quick as possible. And I don't know if Dr. Emmanuel Agogo is still on the call. If you are still on the call, kindly use the raise hand emoji so we can, okay, I doubt if he's on the call. So we're going to proceed to the panel discussion. The questions that we have has been answered by our speakers, and we do not have so many questions again. So I would like to spotlight our speakers so we can see them. 1 minute, please. We would appreciate if our speakers can put on their videos so they can be spotlighted for everyone. All right, we have a question for all our speakers. So, I know we've mentioned it earlier on. In your view, what remains the biggest gap currently that is limiting Africa's ability to effectively prepare for and to respond to infectious disease threats? I will take that again. In your view, what remains the biggest gap currently limiting Africa's ability to effectively prepare for and respond to infectious disease threats? Anyone can go first? Okay, please go ahead, Sada.
Okay, I'll go. I think it's the community engagement piece during preparedness. We can strengthen national public health institutes, we can strengthen our surveillance systems, we can collaborate with each other because that's all within our purview, right? So within MPHIs, we can set up these multi-sectoral systems. We can work a way out how can we strengthen governance and finances and pooling, because everybody talks about finances, but actually there are solutions there. What we actually haven't done is that solid community engagement piece. And that's developing the confidence and the trust that communities have in professionals, public health professionals, and response officers. And I think that's where we start first. We've seen with the latest Ebola outbreak as well, and with recent outbreaks, that really, again, it begins with the communities. Engagement between us as public health professionals with community leaders, not only just civil society organizations, training of, I think I'm just repeating exactly what Kai said in his presentation, but I think that's really what's stopping us. We learn about these things far too late. Even 2 days, 3 days is far too late. We need to be ahead of the game. Kai?
Thanks, Sada. Fully agree, of course. Just to add a few other points, because of course this is my line that I take community-centered approach is probably the most important aspect. and also the kind of ability to translate the national mechanisms down to the community level, as you said, Sadaf. I think that's probably one area where the most still needs to be done. But of course, other aspects that I see as really important is that investment into readiness and kind of operationalization of preparedness plans ahead or when the first signals are detected. I think we have to gain quite a bit of time there. Still, that's a key issue that we see. And then as well, the primary healthcare investment and utilizing primary healthcare and community capacities in preparedness and response. That's what we try to address with that ERPHC framework. I think that's also something, these are the frontline facilities and the providers. So, and right now it's still seen quite fragmented between PHC and emergencies. I think to bring these together will be an important next step.
Yeah, thank you. I think on top of my previous speakers, I just wanted to add that on behalf of the community engagement that we've been talking about, we have been facing situation of misinformation, which is mostly one of the challenge we have been facing, and we try to solve this, but even investing in the other areas like the lab chain and so on, while we don't cut the transmission or we don't face the challenge of misinformation, this has been difficult. So there is no way to at the community level if we bring information as health authority, but then the information is misunderstood. So even if we try other way, that will not be effective. But it's also important to know that this is a change, so we cannot only look to the community engagement without looking to other areas or other pillars. So we need to fund the other pillar. We need to focus on other pillars, but also knowing that even with a rest of all of pillars, without community engagement, without facing the social network misinformation, we will not be successful. So this is what I also want to add here.
Yeah, thank you very much. That was a beautiful response. I don't know if we can take one more question from the audience, if that's okay. All right. So what is the place of infodemic management for BVD, particularly pre-bunking and development of periodic infodemic insights at a national level in a country affected and the more of risk countries? I'll be pasting it in the chat and I'll be taking it again. What is the place of infodemic management for BVD, particularly rebunking and development of periodic infodemic insight at a national level in a country affected and the more at-risk countries? I don't know if anyone understood the question. Yeah.
Happy to take that question as well briefly. So as you know, infodemic management is part of our community protection framework, and we see it as kind of integrated with risk communication, community engagement. But it's really about, it has a strong focus on identifying rumors, misinformation, but also kind of getting an understanding of what are the main concerns, what are the information gaps by the community. And we are focusing a lot on the online environment with infodemic management. And of course, it has a very, very important place in Ebola preparedness and response, and also almost any other emergency preparedness and response. And it's often not as much appreciated as we want to. What is really important is that we identify these rumors and concerns early on, and that it really also is informing operationally the decision making. This is really important, that there is a link to the incident management system, to the EOC, etc. And so we are generating in our organization these infodemic insight reports, and we then elevate this to provide the responders really with the evidence on what are the community concerns and the barriers, etc. So that is really important to then adapt response measures, etc. This is a key aspect to it, because all of this comes back to the aspect of trust that I think we have talked a lot about. That is really kind of the key factor for the adaptation or adoption of communities of our recommended interventions. So for this to have a systematic way of identifying and addressing misinformation is kind of a key component.
Sadaf, please go ahead. Your hand is raised.
Thank you. So I think we have a dilemma here as well, because obviously when there is an outbreak, then we all spring into action, right? So we do our risk communication, epidemic management. But actually, when there are particular countries like DRC or Uganda or other countries where we know that Ebola can happen or other such outbreaks can happen, it's the in-between times that we need to have consistency as well. And this is where the trust, confidence comes into it with communities, because we all have short memories. COVID, what's COVID, right? If you talk about the public in general, and there will be lots of things that people will have different memories of COVID and different, beliefs in terms of some of the social measures that were put in place. So I think we also need to develop strategies where we are engaging constantly, even during peacetime, in terms of health literacy, education, making sure that that awareness stays and exists within our communities, within our public, not just wait for the time when there is an early outbreak happening and then we spring into action. So we do need to think about those strategies for non-health emergency times, for those common outbreaks that happen within certain regions. Thank you.
Thank you. Yeah, you have to, please go ahead.
Yeah, so just wanted to raise one additional point here that most of the time we talk about health problems and we focus on health, but most of them cannot be solved with only by health authority. So this is one of them. We need education here. We need communication here. We need everyone to work together. So this is just just the health authority to solve. We need everyone to be with us. So here is the point that we need multi-sectorial collaboration to solve the problem of infodemic. Thank you.
Wow, thank you very much. That was a beautiful session. And I believe we've come to the end of the webinar today. So I would like to greatly appreciate our speakers, our distinguished speakers, for sharing their knowledge. And we've exceeded our time by 6 minutes. And that was a very valuable perspective they've shared with us today. So we'd like to sincerely thank you very much, our speakers. Our audience, please let's thank our speakers. You can thank them by sharing, using emojis. Thank you so much. We are glad to have you. Thank you very, very much. We do celebrate you. Thank you so much. And we also thank our participants. Like we do say, without you, there is no Get Webinar series. So we sincerely appreciate everyone who has joined from different parts of the world. And you've actively participated in today's discussion. Thank you very much. We've reinforced that strengthening health system requires preparedness right before the crisis happens and stronger surveillance system. We do not have to wait for the pandemic or epidemic before we take action. And on behalf of the Global Emerging Pathogens Treatment Consortium, GET, we sincerely appreciate you for your time and participation. And we'll do say you should follow us on all social media platforms at GET Consortium. And you can also visit our website at www.getafrica.org. The recordings of this webinar will be uploaded on our YouTube channel at Get Africa, so you can as well go back to watch again. And certificates of participation will also be shared to all registered participants alongside the presentation slides of our speakers with their permission. So thank you so much once again, and we have now come to the end of this webinar. We look forward to continue important discussions like this in future editions of the Get Webinar series. Thank you and have a wonderful day ahead. Bye.
Bye. Thank you.
Thank you, speakers. Thank you so much.
Bye. Thank you very much.
Thank you.
Bye.
Bye.